Welcome back to the Radong Smart Review Head and Neck Cancer series. I am your host and examiner.
And I am ready to be in the hot seat.
Today, we are conducting a high-stakes simulation. This is episode 37B, the Salivary Gland Capstone, a mock oral board review.
Sounds good.
So ideally, you've reviewed the previous anatomy and histology modules because today we are putting it all together.
Right.
We've structured this session into 3 major clinical blocks and then a lightning round at the end. Block 1 will cover comprehensive postoperative management and will really dig into the nuances of the close margin.
Right.
Blocks 2 and 3 will test some specific, really high-level decision pivots, specifically how to handle perineural invasion stop points and then the new metastatic biomarker-driven therapy paradigm.
These are the exact scenarios that tend to trip people up on the exams.
Exactly. And to make this effective for you, the listener, we need you to participate. This is an active simulation. I'll ask a question, and then I'm going to say, pause for listener to formulate response.
And you should actually do it.
Yes, I want you to actually pause, speak your answer out loud, commit to a decision, and then listen to the examinee's response. You can compare your logic to hers. Ready?
Ready.
Let's begin. Block 1. Post-operative decision-making in mucoepidermoid carcinoma. Here is your case presentation.
Okay.
You're in clinic. You see 55-year-old woman. She comes in with a history of an incidental finding. She had a 2.5 centimeter mass in her right parotid gland found on imaging for, I think, an unrelated headache.
Okay. No symptoms from the mass itself.
No. She has absolutely no facial weakness and no pain. She underwent a parotidectomy with facial nerve preservation. The pathology report is now on your desk. The surgeon wants to know what to do next. Walk me through your initial approach. Pause for listener to formulate response.
Okay, so before I make any treatment recommendations or commit to a specific plan, I need to extract some very specific pathology details to risk stratify this patient. In salivary gland cancer, the devil is really in the details.
I agree. What's number 1 on your list?
First, I need the histology, which we know is mucoepidermoid. But critically, I need the grade. For mucoepidermoid specifically, the grade is the primary driver of, well, everything. Prognosis, adjuvant management, all of it.
What else?
I need the margin status. And I want to be very precise here. I need the measurement in millimeters. The word close is, it's subjective. I need the number.
Good. Keep going.
I need to know if there's perineural invasion or PNI or lymphovascular space invasion, LVSI, and then the nodes. I need to know if lymph nodes were sampled.
And if they were?
I need to know what levels were taken and how many nodes were examined. I mean, a negative neck with 2 nodes sampled is a very different story from a negative neck with 20 nodes sampled.
Excellent point. Anything else?
Just one more thing. I need to know if a preoperative MRI was performed and if it's available for comparison, especially regarding the nerve status.
Excellent. And that is the first teaching pearl of the session. Examiners reward systematic approaches. If you had jumped straight to, I would treat with 60 gray, you would have missed the boat entirely.
Right, you have to gather the data first.
You must gather the critical data first. The specific margin measurement, grade, and nodal pathology are what drive the decision. You can't treat what you haven't staged.
Understood.
Okay, here is your pathology. The report shows mucoepidermoid carcinoma, intermediate grade. The tumor size is 2.8 centimeters, which makes it a pathologic T2.
Okay, PT2.
The closest margin is reported as 1 millimeter at the deep aspect of the resection. There is no PNI and no LVSI.
1 millimeter. Got it.
A selective neck dissection of levels 2 and 3 was performed, and 0 of 18 lymph nodes were positive. So your final stage is pathologic T2, N0, M0. Does she need postoperative radiation? Pause for listener to formulate response.
This is a nuanced decision. It really falls into a bit of a gray area.
Tell me more.
We have a patient with intermediate grade mucoepidermoid carcinoma and a 1 millimeter margin. If I reference the ASCO guidelines, postoperative RT may be offered for intermediate grade histology or close margins.
May be offered.
Right. It doesn't use the mandatory should language. But I need to interpret that margin. Per RTOG 1008 criteria, a margin of 1 millimeter or less is technically considered close.
So, taking all that into account, what is your final recommendation to the patient?
Given the combination of factors, specifically the intermediate grade histology paired with a technically close margin of 1 millimeter, I would recommend postoperative radiation therapy, or PORTEN.
And your rationale?
My rationale is that while intermediate grade alone might be observed, that minimal surgical buffer just increases the risk of local recurrence. However, I have to acknowledge to the patient that this isn't absolutely mandatory.
Because of that ASCO language.
Exactly. ASCO's maybe offered language implies a conversation. If the patient was, say, strongly opposed to radiation toxicity, observation with close surveillance is a valid alternative for shared decision-making. It's not like high-grade or positive margins where radiation is standard. But my recommendation to minimize local recurrence risk is to treat.
Correct. And that teaching pearl is vital. ASCO language matters. Maybe offered implies a conversation. It implies that omitting radiation isn't necessarily wrong, but adding it reduces risk. This is different from high-grade or positive margins, where the recommendation is much stronger. You need to articulate that difference to show you understand that spectrum of risk.
Right. If this were high grade, we wouldn't be having much of a debate here.
Exactly. So let's say she agrees with your recommendation. She wants to be aggressive and reduce her recurrence risk. What dose do you prescribe? Pause for listener to formulate response.
Because we have that 1 millimeter margin, which qualifies as close per the RTOG 1008 criteria, I would treat to 60 to 66 gray to the tumor bed.
And which end of that range would you favor?
I lean toward 66 gray specifically.
Mm-hmm.
This is the dose tier for close or positive margins. The standard adjuvant dose for negative margins is 60 gray, but the high dose tier of 66 reflects that elevated risk of local recurrence when you just don't have a wide surgical buffer.
Correct. RTOG 1008 uses 1 millimeter or less as the threshold. If it were truly negative, say 5 millimeters, and you were treating for other reasons, you might stay at 60 gray. But for close margins, you push to 66 gray. Now, regarding the lymph nodes, do you cover the neck electively? Pause for listener to formulate response.
No, I would not include elective neck RT in this case.
Walk me through why. We treat the neck in almost all squamous cell carcinomas. Why not here?
This patient had a selective neck dissection of levels 2 and 3, and 0 of 18 nodes were positive. So the dissected levels have been pathologically cleared.
And the guidelines.
Per ASCO, elective nodal irradiation may be offered for T3 to T4 tumors or high-grade tumors. This patient had a T2 intermediate-grade tumor with a negative surgical dissection. The indication for elective neck coverage just isn't met. The risk of occult disease in the undissected neck for this specific presentation is low enough that I think we can omit the toxicity.
Correct. Do not reflexively add elective neck RT for all head neck cancers. It is a common trap on the boards. For salivary gland tumors, ASCO supports elective nodal irradiation for T3, T4, or high grade, not T2 intermediate grade with a cleared neck.
Okay, talk to me about your technique. How are you setting this up? Pause for listener to formulate response.
IMRT is preferred here to maximize conformality and spare normal tissue. For simulation, I'd place her supine with a thermoplastic mask for immobilization.
Anything else for the setup?
I'd have her shoulders pulled down to clear the beam path, probably using jump ropes or foot straps. And critically, I would fuse a postoperative MRI to the planning CT for target delineation if it's available. The parotid bed can be really difficult to visualize on CT alone.
And for daily treatment?
For image guidance, I'd use daily cone beam CT to ensure setup accuracy.
And your volume? The GTV is the surgical bed. Based on preoperative imaging and operative findings, clips are very helpful here. The CTV includes the entire parotid bed with an appropriate anatomical margin. The PTV expansion is typically 3 to 5 millimeters, based on my institution's immobilization and IGRT capability.
Any key constraints you're watching?
Absolutely. A key constraint here, and one I would prioritize, is sparing the contralateral parotid gland. I want to keep that mean dose to 25 gray or less to preserve salivary function and prevent long-term xerostomia.
Excellent. IMRT with MRI fusion is the standard. Now let's throw a wrench in the gears. Here's a subcase twist.
I'm ready.
You obtain that post-operative MRI for treatment planning that you mentioned. The radiologist calls you. They see 2 millimeters of abnormal enhancement along the mastoid segment of cranial nerve 7, extending toward the stylomastoid foramen.
Okay.
This was not seen on preoperative imaging. However, your pathology report explicitly said no P&I. How do you handle this? Pause for listener to formulate response.
This is a difficult scenario, the discordance between imaging and pathology. It requires a really careful evaluation before I change my treatment plan. I can't just ignore it, but I can't blindly treat it either.
So what is step 1?
First, I'd request a formal neuroradiology review with the direct side-by-side comparison to the preoperative MRI. I need to determine if this enhancement is truly new or if it could just represent post-surgical change. Things like edema, inflammation, or enhancement on the surgical tract can, They can mimic disease in the immediate post-op setting.
Okay, let's say the radiologist says, I'm not sure, it looks suspicious, but it could be post-op changes.
If the comparison is indeterminate, I would consider a short interval repeat MRI, maybe in 6 to 8 weeks, to assess for evolution. Post-surgical changes should generally improve or resolve over time as inflammation subsides. True perineural disease would either remain stable or progress.
And if, after review, the consensus is that this represents true subclinical perineural spread despite the negative pathology, maybe the surgeon peeled the tumor off the nerve, but microscopic disease remained that the pathologist just didn't section.
Then I have to modify my plan. I mean, imaging can sometimes see what the scalpel missed or what the pathologist didn't sample. Per ASCO, involved nerves may be covered with elective or intermediate dose to the skull base.
So what does that look like on your plan?
I would extend my CTV to include the facial nerve pathway up to the stylomastoid foramen. I would treat that pathway with an intermediate dose of 54 to 60 gray.
Would you go higher? Would you chase it all the way into the brainstem?
No, I wouldn't. I would not extend beyond the stylomastoid foramen into the tympanic or labyrinthine segments unless there was clear evidence of more proximal disease. And I wouldn't take it to 70 gray unless I had gross measurable disease. 54 to 60 gray covers microscopic extension adequately while respecting the tolerance of the nerve and surrounding structures.
Correct. That is the teaching pearl. Do not reflexively treat imaging findings without radiology correlation. Postoperative changes are notorious for mimicking perineural spread. But conversely, don't ignore findings just because pathology was negative. The systematic approach is correlate, consider interval imaging if indeterminate, and then act.
Right.
One last question on this block. What about concurrent chemotherapy? Pause for listener to formulate response.
Concurrent chemotherapy. Per ASCO guidelines, concurrent chemotherapy may not be routinely offered outside a clinical trial for salivary gland malignancies. This applies to both adjuvant and definitive settings. I know RDOG 1008 is testing this question for high-risk patients, but until we have those results, concurrent chemo is just not standard of care for salivary gland cancers.
Perfect. Do not reflexively add cisplatin just because you do it for squamous cell.
Okay.
ASCO explicitly discourages it outside of trials. Let's move to block 2.
Okay.
This is the stop point decision. We're dealing with adenoid cystic carcinoma with clinical perineural spread.
This is the classic how high do I go scenario.
Exactly. Here is the case. 48-year-old man. He presents with a right submandibular gland mass. He reports 6 weeks of tongue tingling on the right side.
So symptoms.
Yes. MRI shows a 3-centimeter submandibular mass with abnormal enhancement along the lingual nerve, which is a branch of V3 extending toward the foramen oval. There is no enhancement beyond the foramen oval into Meckel's cave. A PET scan shows an FDG avid primary with no nodal or distant disease. On exam, he has demonstrable decreased sensation in the right anterior tongue. How do you characterize this presentation? Pause for listener to formulate response.
This patient has clinical perineural tumor spread, or PNS. This is distinct from incidental PNI.
And why is that distinction so important?
Because he has symptoms, the tingling and numbness, and he has radiographic findings. The combination of symptoms plus imaging findings defines clinical or radiographic PNS. This is different from incidental PNI found only on a slide by a pathologist in an asymptomatic patient, and this distinction drives management, specifically regarding the extent of nerve coverage. Clinical PNS generally requires tracking the nerve pathway to the skull base because the burden of disease is so much higher.
Correct. PNI is histologic. PNS is clinical and radiographic. Management differs significantly, so he undergoes resection. Pathology comes back as adenoid cystic carcinoma. How do you want this characterized?
Pause for listener to formulate response.
For adenoid cystic carcinoma, or ACC, the grade is determined by the solid component. I need to know that percentage. Greater than 30% solid component is associated with high-grade behavior and worse outcomes. Less than 30% solid, whether it's cribriform or tubular, generally behaves more favorably.
What else on the path report? I also need margin status, the specific nerve involved, and critically, whether the proximal nerve margin at the skull base is clear.
Okay, here's the report. Adenoid cystic carcinoma, predominantly cribriform pattern with less than 10% solid component. Tumor size is 3.2 centimeters, pathologic T2. Margins are negative at 5 millimeters. However, perineural invasion is present, involving the lingual nerve. The proximal nerve margin is negative. Neck dissection of levels 1 and 2 shows 0 of 12 nodes positive. Does he need port? Pause for listener to formulate response.
Yes. Per ASCO guidelines, RT should be offered to all patients with resected adenoid cystic carcinoma.
Notice the language there.
Yes, the language is different from the previous case. For ACC, it says should be offered. It's a much stronger statement. And plus, this patient has clinical perineural tumor spread with symptoms and imaging findings and a named nerve involved. Port is clearly indicated regardless of the negative margins.
Correct. Should be offered. This reflects the neurotropic biology and high local recurrence risk of ACC. Now, the million-dollar question. How do you handle the nerve? Where do you stop? Pause for listener to formulate response.
I need to track V3 retrograde. The lingual nerve connects to V3, which exits the skull base at the foramen oval. My strategy is to include the nerve pathway in my CTV right up to the foramen oval.
Do you go further into Meckel's cave?
No. Critically, the preoperative MRI showed enhancement to the foramen oval, but not beyond. There was no enhancement in Meckel's cave. Therefore, my stop point is the foramen oval.
You're sure?
I am. I do not extend into Meckel's cave or the cavernous sinus without imaging evidence of more proximal disease. Per ASCO, involved nerves may be covered with elective or intermediate dose. I treat that nerve pathway to 54 to 60 gray.
Why not just treat Meckel's cave to be safe?
Because the toxicity penalty is high. Treating Meckel's caves increases the dose to the temporal lobe in the brainstem. If there's no evidence of disease there, the risk of toxicity just outweighs the benefit of elective coverage in that sensitive area.
Correct. The stop point is driven by imaging. You track to the foramen by default in this scenario. You only extend beyond the foramen if imaging shows enhancement proximal to it, or if symptoms strongly suggest intracranial involvement. Don't reflexively chase into Meckel's cave for every case.
Got it.
What dose do you take the tumor bed to? Pause for listener to formulate response.
60 gray. This is ACC with negative margins. Even though it's ACC, if the margins are clear, 60 gray is the standard. If the margins were close or positive, then I would escalate to 66 gray.
Correct. 60 for negative, 66 for close or positive. Do you cover the neck electively? Pause for listener to formulate response.
This is a T2N0 adenoid cystic carcinoma with a negative neck dissection. ACC has historically low nodal metastasis rates. I think it's reported at only 5 to 8%.
So what's the call?
Given the T2 stage, the negative dissection, and that low intrinsic risk, I would typically omit elective neck RT. However, I'd probably individualize this based on a multidisciplinary discussion, but my standard would be to omit.
Correct. Omission is defensible and standard for N0 ACC. What about concurrent chemo here? Pause for listener to formulate response.
No concurrent chemotherapy. Again, per ASCO, it may not be routinely offered outside a clinical trial. This rule applies to ACC just as it does to mucoepidermoid.
Good. Now let's look at a subcase twist. 18 months later,
The other shoe drops.
the patient completes treatment and does well initially, but at his 18-month surveillance, MRI shows new enhancement in Meckel's cave on the right, with subtle V3 thickening proximal to the foramen oval. He reports new right V2 numbness. His cheek is now numb. How do you manage this? Pause for listener to formulate response.
Okay, this is a local recurrence with intracranial extension, and crucially, it's in a previously irradiated field. This is a bad situation.
What's your first step?
Step 1 is to confirm recurrence. I need to distinguish this from post-treatment changes or necrosis, though the new symptoms make recurrence very likely. I'd get a neuroradiology review, and if it's safely accessible, a biopsy.
Assume it's confirmed recurrence.
Step 2 is to assess resectability. Surgery is always preferred for recurrence in a previously irradiated field if it's at all feasible. However, involvement of Meckel's cave and likely the cavernous sinus makes this almost certainly unresectable.
Those left.
Step 3. For unresectable recurrence in a previously irradiated field, my options are re-irradiation or systemic therapy. Per NCCN, clinical trial enrollment is the preferred option for re-irradiation. Retreating the skull base carries massive risks: brainstem necrosis, temporal lobe necrosis, carotid blowout. It's not something to take lightly.
And systemic options.
I would order broad NGS testing. But, systemic options for ACC are modest. Axitinib is often used. It can provide disease stabilization, but the objective response rate is only about 3%. It stops growth. It rarely shrinks tumors. I'd present this at tumor board with a strong preference for a clinical trial.
Correct. Don't overstate the systemic options. They are stability drugs, not miracle cures. Speaking of miracles, the medical oncologist asks you, hey, should we send for NTRK testing for this ACC? What do you say? Pause for listener to formulate response.
I would say broad NGS is reasonable, but I would temper expectations regarding NTRK. NTRK fusions are the signature biomarker for secretory carcinoma, where lorlatinib achieves a 92% response rate.
That's right.
But they're extremely rare in ACC. For ACC, the biomarker story is just much less exciting.
Correct. Do not conflate your histologies. NTRK is the star for secretory carcinoma, not ACC. Let's move to block 3.
Okay.
The biomarker-first paradigm. We are dealing with metastatic salivary duct carcinoma.
This is where the management has changed the most in recent years.
Absolutely. Here is the case. 62-year-old man, 4-centimeter left parotid mass, progressive left facial weakness over 3 months. He is a heavy smoker.
Okay.
MRI shows a 4.5-centimeter deep lobe parotid mass with skull base invasion at the stylomastoid foramen and encasement of the petrous internal carotid artery. He has complete left facial paralysis, House-Brackmann 6.
Wow.
CT chest shows 3 pulmonary nodules measuring 8, 6, and 5 millimeters. A PET scan shows an intensely FDG-avid primary. The lung nodules are only mildly FDG-avid. FNA of the parotid confirms salivary duct carcinoma, high grade. What is your next step?
Pause for listener to formulate response.
Stop. Before I can determine treatment intent, I need a tissue diagnosis of those lung nodules.
Why is that so critical? The primary is high-grade salivary duct carcinoma, or SDC, which is aggressive. But the lung nodules are only mildly avid. I absolutely cannot assume they are metastatic. They could be benign, or given its smoking history, a second primary lung cancer. If they're metastatic, he's stage 4C, and my approach is systemic therapy first. If they're benign, he's M0, and I pursue definitive local therapy. I must biopsy the largest pulmonary nodule.
Correct. Teaching pearl. When a finding changes treatment intent from curative to palliative, you must confirm it with tissue. Never assume M1 status without proof, especially in a smoker where a second primary is possible.
Right.
Okay. The lung biopsy confirms metastatic salivary duct carcinoma. What is your treatment approach? Pause for listener to formulate response.
This is stage 4C salivary duct carcinoma. So the first treatment is the biomarker panel. For metastatic salivary gland cancers, I order comprehensive testing, androgen receptor or AR, HER2, NTRK fusions, and TMB with MSI status.
Why those specific tests for this histology?
Because salivary duct carcinoma is approximately 90% androgen receptor positive. It behaves very similarly to ductal breast cancer or prostate cancer in its receptor profile.
And what therapy does that point you to?
Given this, I anticipate starting combined androgen blockade, typically leuprolide plus bicalutamide. This achieves an objective response rate of approximately 42% per phase 2 data. That is huge compared to chemotherapy.
And if he's HER2 positive?
If HER2 is amplified, then trastuzumab plus docetaxel is the choice, achieving a 60 to 70% response rate. If NTRK is present, which is less likely in SDC but possible, lorlatinib works. If TMB is high, pembrolizumab is an option. The key is I would not start traditional cytotoxic chemotherapy as first line. The response rates for biomarker-driven therapy just dwarf cytotoxic chemo.
Correct. The biomarker-first paradigm is the standard. A 42% response with androgen blockade versus maybe 15 or 20% with toxic chemo. It's not even close. Now, what about the primary? It's big, it's ugly, it caused facial paralysis. Do you treat it? Pause for a listener to formulate response.
The primary is unresectable due to the skull base invasion and carotid encasement. And since he has M1 disease, systemic therapy takes priority. Definitive intent local therapy. Treating to 70 grays is not appropriate because the patient has incurable metastatic disease.
So no local therapy at all?
Well, I would consider palliative RT to the primary only if he develops significant local symptoms like uncontrolled pain, bleeding, or impending airway compromise. But right now, with lung mets confirmed, I would not initiate local treatment.
Correct. Distinguish curative from palliative. Palliative RT is for symptoms. You don't treat an incurable patient to 70 degree just because the tumor is there. Here's the twist.
Okay.
Lonal progression on systemic therapy. The biomarkers come back. AR positive at 95%, HER2 negative. He starts combined androgen blockade. At his 4-month restaging, the lung nodules are stable. The drug is working systemically.
That's good news.
However, the primary tumor has progressed locally. There is new left V3 involvement, and he has severe left-sided facial pain, rated 8 out of 10. How do you manage this?
Pause for listener to formulate response.
This is a critical decision point. Systemic therapy is controlling the life-limiting distant disease. The lungs are stable. So I would continue the systemic therapy. I wouldn't switch drugs yet because we're getting benefit where it counts most for survival.
But what about the local problem?
Exactly. The local progression is causing severe morbidity. This is a clear indication for palliative RT. My goal is symptom control, not cure.
What dose? Pause for listener to formulate response.
I would treat to 30 gray in 10 fractions. This is a standard palliative regimen. It provides meaningful pain relief, but limits the treatment duration to 2 weeks and keeps toxicity manageable.
You wouldn't go higher.
I would explicitly not escalate to definitive doses like 70 gray. He is still incurable. 30 gray in 10 fractions allows him to get back to his life and continue his androgen blockade. Correct. Palliative RT is 30 gray in 10 fractions. Do not get tempted to go to 70. The goal is symptom control. Now, the surgeon calls you and says, look, this is salivary duct carcinoma. It's aggressive. Shouldn't we be more aggressive with the primary? Why are you only giving 30 gray? What do you say? Pause for listener to formulate response.
I would explain that aggressive means evidence-based management, not just more treatment. This patient has M1 disease. Treating the primary to 70 gray will not cure him, but it will subject him to 7 weeks of toxicity, mucositis, and time away from home. In this context, being aggressive means confirming biomarkers, using targeted therapy like the androgen blockade, and palliating his symptoms promptly and efficiently.
So it's about being smart, not just throwing more radiation at it.
Exactly. Subjecting an incurable patient to high-dose definitive radiation isn't aggressive, it's potentially harmful.
Ideally stated. Aggressive means the correct treatment at the correct time. All right, take a breath. That was the heavy lifting. Now we're moving to the lightning round. Rapid fire decisions. 30 seconds per question. Don't overthink it. Give me the decision and the why.
I'm ready.
Case A. 50-year-old woman. Parotid cell carcinoma, pathologic T2 and 0, negative margins at 3 millimeters, no PNI, no neck dissection was performed. Does she need port? Pause for listener to formulate response.
Observation. Actinic cell carcinoma is generally low-grade. She's T2 with negative margins and no adverse features. For ASCO, port may be offered for close margins or adverse features. She has neither. But the caveat is that actinic cell is a long con histology.
Yeah.
It can recur 5-10 years later. She needs long-term surveillance.
Correct. Observation is defensible. Case B, 45-year-old man. Minor salivary gland tumor of the hard palate. Pathology shows secretory carcinoma with positive margins. What biomarker must you test? Pause for listener to formulate response.
NTRK fusion testing. It's mandatory. Secretory carcinoma has a massive rate of NTRK fusions. The railroad-trectinib achieves a 92% response rate. You cannot miss this target.
Correct. Secretory equals NTRK, case C, 60-year-old man, submandibular adenoid cystic carcinoma. Completed surgery and RT 5 years ago. Now has 4 lung nodules on surveillance CT. Biopsy confirms metastatic ACC. He is asymptomatic. What do you recommend? Pause for listener to formulate response.
Expectant management. Observation. ACC lung metastases are often really indolent. Patients can live for years with metastatic disease. If he's asymptomatic, there's no need to pull the trigger on systemic therapy yet. Watch and wait.
Correct. The long con applies to METs too. Case D, 70-year-old woman. Parotid mucoepidermoid carcinoma, high grade, pathologic T3 and 2B with 3 of 15 nodes positive, and 1 has extranodal extension, or ENE. Margins are negative. Does she need chemotherapy with irradiation? Pause for listener to formulate response.
No routine concurrent chemo. She has ENE, which is a trigger for chemo in squamous cell carcinoma, but this is a salivary malignancy. Per ASCO, concurrent chemo may not be routinely offered. I would check for a clinical trial like RTOG 1008. If not available, I treat with port alone, acknowledging the lack of data for chemo.
Correct. ENE in salivary does not equal chemo the way it does in squamous cell. Excellent work.
Thank you.
That brings us to the end of the session. Let's recap the rapid-fire board pearls. Summarize the port indications for me.
Okay. For adenoid cystic carcinoma, RT should be offered to all resected cases. The language is strong. For high-grade, positive margins, T3 to T4, or nodal mets, port should be offered. For intermediate grade or close margins, port may be offered. That's the shared decision-making zone.
Margins.
Per RT 1008, 1 millimeter or less is a close margin. Close or positive get 60 to 66 gray. Negative margins get 60 gray.
Perineural rules.
Distinguish PNI, which is histologic, from PNS, which is clinical or radiographic. For clinical PNS, track the nerve to the skull base foramen. Stop at the foramen if imaging stops there. Only extend if you see proximal disease. Dose is 54 to 60 gray to the nerve pathway.
And finally, the biomarker hierarchy.
The first treatment for M1 is the biomarker panel. For salivary duct carcinoma, check AR and HER2. For secretory carcinoma, check NTRK. For adenoid cystic, check NGS but expect limited options.
Perfect. If you can handle these scenarios, you can handle salivary gland on oral boards. That's episode 37B, the salivary gland capstone. This completes the salivary gland block. Next up is episode 38, sign-on nasal block, anatomy, histologic diversity, and orbital proximity.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.